Hello everyone, welcome back to our channel. I am Dr. Ashmita. Today I want to discuss about a clinical case scenario which is placed as an ASCII chart during the practical exams for both MBBS and MD or DNB Pathology students. So let us begin by reading out this question. A 15-year-old boy presented to OPD with complaints of fever, malaise, nausea, vomiting, abdomen pain, yellowing of eyes, dark urine, pale stools. On history, he has revealed that he has been eating pani puri in a roadside stall near his school for the past 1 month. Lab findings show total bilirubin 10 mg per deciliter. Normal should be between 0.3 to 1.2. Direct bilirubin 5.5 mg per deciliter. Normal range is below 0.3 and alanine transaminase ALT or SGPT is 3100, reference value is below 50, and AST aspartate transaminase or the SGOT is 2700 international units per liter, where the reference value is below 50 international units per liter. Alkaline phosphatase ALP, that is 290 international units per liter, reference value is between 50 to 300 international units per liter. And a photograph has been attached showing you this yellowish discoloration of the sclera. So, from this given question, what are the clues that we can derive that help us come to a diagnosis? Firstly, it is a 15-year-old child. Age group is given, and the symptoms of fever, malaise, they indicate some infection, underlying infection. And also, given the history of nausea, vomiting, abdomen pain with history of pani puri eating in the roadside stall. So outside food intake. All this are suggestive of acute gastroenteritis, some gastroenteritis kind of symptom. And especially outside food intake means there can be possibility of contaminated food intake. And also there's yellowish discoloration of the eyes. So it shows jaundice. Dark urine and pale stools. These indicate liver involvement. There is some liver involvement. From the clinical history, we have derived that there is some liver involvement with some infection kind of pathology. And from the lab findings, lab clues are total bilirubin is raised, direct bilirubin is raised, alanine and aspartate, all these two transaminases are elevated, alkaline phosphatase, the ALP is normal. So this total bilirubin means it includes both the indirect bilirubin and the direct bilirubin. Total bilirubin is given as 10, direct as 5.5. That means you can deduce 4.5 as indirect bilirubin. The normal reference value for direct bilirubin is 0.3. For indirect, it is 0.8. So this indicates both are on higher level, both are raised. So it shows mixed pattern of hyperbilirubinemia. Hyperbilirubinemia is a mixed pattern, both indirect plus direct, both are on higher level. And also the transaminases ALT, AST, they are raised. Transaminases are raised, but alkaline phosphatase is within the normal range. ALP is within the normal range. So we have deduced from the clinical clues that there is some liver involvement and some infection kind of pathology is there. And from this we have deduced that this mixed hyperbilirubinemia with rise of transaminases and normal phosphatase. To come to a specific diagnosis, we need to understand the normal physiology of bilirubin. So let's start from bilirubin. Bilirubin is made from where? It is made from the heme. Heme comes from where? RBCs. So let's begin the story from RBC. The normal lifespan of RBC is 90 to 120 days. As it gets older, when it reaches the spleen, Upon reaching the spleen has macrophages which take up these old RBCs and break them down. So these RBCs, they break down, release hemoglobin. This hemoglobin means it is made up of heme and globin protein. Here we are not concerned about the globin protein, we need this heme. Inside the splenic macrophages, heme is converted to biliverdin with the help of enzyme called heme oxygenase. Heme oxygenase. And this biliverdin converted to bilirubin by biliverdin reductase. Biliverdin reductase. So just remember, the old RBCs broken down in the splenic macrophages, ultimately bilirubin is formed. So this bilirubin, it reaches the circulation. In the circulation in the blood, bilirubin is in bound form to albumin. Albumin is a protein which acts as a transport. It acts as a transport protein. This bilirubin, on reaching the liver has hepatocytes. These hexagonal shaped cells are the hepatocytes. Surrounding it are these biliary canaliculi. So, this bilirubin, on reaching the hepatocytes take up this bilirubin inside them. But albumin is not taken up, it is left behind. Only the free bilirubin enters the hepatocyte. This free bilirubin is called indirect or it is in unconjugated form. It is in unconjugated form. Inside the hepatocyte, there is an enzyme called UGT, UDP glucuronyl transferase. The function of UGT is to add, it will add glucuronic acid to this indirect bilirubin and converts converts into conjugated or the direct bilirubin. This direct bilirubin is formed within the hepatocyte. This direct bilirubin now via this MRP2 port. Hepatocyte has ports or channels called MRP2 which is connected to this biliary canaliculi. This conjugated bilirubin formed inside the hepatocyte they are transported via this port into the biliary canaliculi. These are the biliary canaliculi surrounding the hepatocytes. They enter the biliary canaliculi. All this biliary canaliculi, they merge and form this right and left hepatic ducts. Right and left hepatic ducts. Ultimately, these both merge to form common hepatic duct. Here, this structure, this is the gallbladder producing bile. It will concentrate and secrete bile via the cystic duct. This is the cystic duct. The cystic duct merges with common hepatic duct. Via common hepatic duct, what is coming is the conjugated bilirubin. So, conjugated bilirubin is ultimately secreted into the bile. Finally, these two common hepatic duct, cystic duct, they merge and form common bile duct, which open into the intestine, that is the duodenum, where even pancreatic duct merges. So what you have to remember is the indirect bilirubin enters the hepatocyte, gets conjugated, and via MRP2 port, they are secreted into this biliary canaliculi and all these biliary canaliculi form right and left hepatic ducts. Right and left hepatic ducts, common hepatic duct, merge with cystic duct, form common bile duct, finally open into the intestine. That means that is the conjugated bilirubin or the direct bilirubin is thrown into the intestine. It travels in the intestine. The intestine has bacteria. The intestinal bacteria convert conjugated bilirubin into urobilinogen into urobilinogen. Urobilinogen is formed in the intestine. Some part of the urobilinogen, about 5 to 10%, will be reabsorbed. It will be absorbed back into the liver via this enterohepatic circulation. Via this entero means intestine, hepatic is liver. Enterohepatic circulation, it is reabsorbed back into the liver where This conjugated, this urobilinogen, it may re-enter into the biliary canaliculi and re-enter this loop from the biliary canaliculi again secreted into the intestine. It may re-enter this loop or it may get absorbed into the circulation. It may go into the circulation. Once it reaches the circulation, from here they reach kidneys and via kidneys they are excreted into the urine. So normal urine contains some part of urobilinogen, and in the intestine the balance 95 to 90 to 95% of urobilinogen, it gets further converted into stercobilinogen, and further into oxidized into stercobilin. The stercobilin is responsible for the brown color of stools. If stercobilin is absent, it will result in pale stools. So this is about the normal physiology of bilirubin. Coming to the enzymes, this hepatocyte, this hepatocyte has two enzymes. Hepatocytes has two enzymes, alanine transaminase, aspartate transaminases. Whenever there is a liver cell injury, it will result in rise of alanine and aspartate transaminases. Whereas this biliary canaliculi, these are lined by epithelial cells that secrete alkaline phosphatase. So whenever there is problem pathology in this biliary canaliculi or the bile duct, it will result in increase in ALP. So rise in alanine and aspartate rise of transaminases indicate liver cell pathology. Rise of ALP indicates more of gallbladder or the biliary. Here this biliary, these are the biliary or the gallbladder obstruction. And ALP, this alkaline phosphatase, it is non-specific. It is not only secreted by this liver or this biliary tract, but also it is synthesized by bones, kidneys, placenta. And hence, whenever ALP is raised, you should not jump into liver pathology. You should also confirm the liver pathology with additional one enzyme called GGT means gamma glutamyl transferase, gamma glutamyl transferase, which is specific for hepatobiliary origin. If along with ALP, GGT is also raised, it confirms hepatobiliary origin. If only ALP is raised, there is no GGT rise. It may indicate bone, renal, or placental pathology. So, confirmation with GGT is important whenever ALP is raised. Yes. So, here I would like to add, this is the normal physiology till now. Whenever there is a rise in indirect bilirubin, that is before reaching the liver, indirect bilirubin or the unconjugated bilirubin, whenever it is raised, it indicates prehepatic causes, prehepatic pathology. For example, it can be hemolytic anemia, whereas massive destruction of RBC will release massive production of unconjugated bilirubin. Whenever there is a rise in conjugated bilirubin here, the problem lies in the liver cell within the hepatocyte or within the liver, or it can be in this gallbladder. So conjugated bilirubin will indicate hepatic causes. Till here, the hepatocytes, minor biliary canaliculi, it indicates hepatic pathology, hepatic causes. From here, the hepatic ducts, the gallbladder, bile duct, these will indicate post-hepatic causes. Post-hepatic causes can be any gallbladder obstruction because of a stone or a tumor or strictures as well. So to differentiate between hepatic and post-hepatic, alkaline phosphatase comes into play. In post-hepatic, because of this gallbladder stones, there is obstruction anywhere from here, strictures, tumors. There is rising pressure in this biliary canaliculi. It is called cholestasis. Cholestasis. Because of this bile accumulation, there's increased pressure. Because of that reason, the epithelial cells of the biliary canaliculi they secrete ALP. So, and the hepatic causes, coming to the hepatic causes, it can be because of hepatitis, inflammation of the liver, and viral hepatitis is the most common reason. Whenever there is viral hepatitis, whenever there is a viral hepatitis, the liver cell, it may either undergo necrosis, there are two outcomes, necrosis, and few others, they become inflamed and release of massive cytokines. So whenever there is a necrosis, this unconjugated bilirubin or the indirect bilirubin on reaching the hepatocytes, because of loss of few of the necrosed hepatocytes, their liver is unable to conjugate it properly. So there will be rise in this unconjugated bilirubin and also few other surviving hepatocytes. They are inflamed. They will conjugate. They will help in conjugation, but because of massive release of cytokines, this biliary canaliculi, they can become plugged. They can become plugged. They become partly blocked. They'll be blocked. So the excretion into the bile will be improper. So improper excretion into the bile. Because of this block, improper excretion into the bile. So because of that reason, the conjugated bilirubin may backflow. It may backflow into the circulation that results in rise in both conjugated bilirubin. For this reason, in viral hepatitis or in hepatic pathology, there is rise in both direct and indirect bilirubin. That is called the mixed hyperbilirubinemia. So coming back to our case, in our case, both direct and indirect are raised. So it has mixed hyperbilirubinemia pattern and transaminases are raised. Both confirm these are like hepatic pathology. It confirms hepatic pathology. Alkaline phosphatase is normal. So gallbladder post-hepatic causes are ruled out. And specifically in this case, given the history of this outside food intake, jaundice symptoms, the most probable diagnosis will be acute viral acute viral hepatitis. Given this age of a child and roadside food, the most common, like given the history of outside food intake, it indicates fecal-oral transmission. The fecal-oral transmission seen in only two cases, hepatitis A, hepatitis E, both show fecal-oral transmission. But hepatitis is the most common reason for fecal-oral transmission, especially in children. So the most probable diagnosis here becomes acute viral hepatitis because of hepatitis A virus. So your probable diagnosis is acute viral hepatitis because of hepatitis A virus. So hepatitis A and hepatitis E, let's see the differences. The common age group is children and young adults. So this is for children. For hepatitis E, children and young adults. They are affected by hepatitis E. Hepatitis A have fecal-oral route of transmission. Hepatitis E also has this fecal-oral route of transmission. Also, zoonotic spread is seen. Zoonotic means via pigs. Via pigs, that means eating undercooked infected pig meat. And incubation period is the same, 15 to 50 days. 15 to 50 days. So that means 2 to almost 6 weeks. In our question, it is 1 month, past 1 month. So 4 weeks incubation period is matching also. Coming to the second question, what are the causes of hepatitis A? The causes of hepatitis A are The causes of viral hepatitis are infections because of infections caused by viruses such as hepatitis A, B, C, D, E. Hepatitis virus, most commonly known by all. Other viruses are cytomegalovirus, Epstein-Barr virus, herpes simplex virus. And non-infectious causes are also present. They are the drug-induced. Drug-induced hepatitis most commonly occurs with paracetamol and isoniazid. In that particular given question, there's no drug history mentioned, so we have ruled out the drug history also, drug-induced hepatitis. Also, there can be toxin-induced hepatitis, autoimmune, and ischemic hepatitis. These are the other causes for hepatitis. Complications of this acute hepatitis are, especially with hepatitis A, there can be fulminant hepatic failure. Fulminant means there is a and explosive onset, sudden explosive onset, and it will rapidly progress to liver failure. That is fulminant hepatic failure. Rarely they cause relapsing hepatitis in 10 to 15% of cases. Other complication can be cholestatic hepatitis because of prolonged jaundice, and it may cause pruritus. These are the few complications of acute viral hepatitis. So we are done with the three questions. So let us see few viva questions that can be helpful for us. So what is the route of transmission for hepatitis A? We have studied these are the fecal-oral route of transmission, shows fecal-oral route. Incubation period is 15 to 50 days, roughly 2 to 6 weeks. Where does the virus replicate first? So the virus first replicates in the oropharyngeal epithelium and the intestinal epithelium. It replicates in the oropharyngeal and the intestinal epithelium. Is there a carrier state for this hepatitis? Yes or no? For hepatitis, it is usually self-limiting, so there is no carrier state because the virus they are eliminated. They are eliminated completely by the host immune system, and there is no carrier stage present. The key diagnostic test for acute infection here in hepatitis A is IgM antibody of hepatitis A virus. IgM for hepatitis A virus is the key diagnostic test. This is tested in the serum levels. What are the phases of this illness? There are few phases. The first is the asymptomatic phase, that is the incubation period where the virus replicates, that is asymptomatic. There is a prodromal phase or the pre-icteric phase where only there is fever malaise due to this interleukins like TNF alpha interleukin 1, and there is an icteric jaundice phase, that is yellowish discoloration with pale stools and dark urine, and there is a recovery phase where the infection has been completely eradicated. Typical liver function test pattern in hepatitis A is the alanine transaminase, aspartate transaminase are increased with alkaline phosphatase normal levels, and there is mixed hyperbilirubinemia, that is total bilirubin is raised, indirect is raised, direct bilirubin is also raised. So there is mixed hyperbilirubinemia. Also, I would want to have forgotten to mention about why there is dark urine, why there is pale stool. In acute viral hepatitis, because this conjugated bilirubin is rising in the blood, it will come back into the circulation. Via circulation, it will reach kidneys and excreted into the urine. This conjugated bilirubin gives tea color. It gives a tea color or the dark urine. And pale stools because there's lots of inflammation, there's a block in the biliary canaliculi. So the Conjugated bilirubin, they does not reach the intestine. Here there's a block. It does not reach here. So intestine does not convert this. First of all, conjugated bilirubin does not enter the intestine. That means there's no urobilinogen, there's no stercobilinogen, there's no stercobilin. Therefore, the brown color is not given by stercobilin. It will lead to pale stools as in our case. So, in acute viral hepatitis, because of increase in conjugated bilirubin in the urine, there's tea color urine that is secreted via kidneys into the urine, and there is no stercobilin in the intestine. Because conjugated bilirubin does not enter the intestine, the pale color of stools is present, as seen in our case. Pale stools, dark urine. So, this is all about the acute viral hepatitis. If you like this video, please like, share, and subscribe. Thank you.